Okay, so the next lecture is common foot and ankle disorders. So the objectives of this lecture are to understand the importance of bony and soft tissue structures of the foot and ankle, to get a concise idea on common foot and ankle disorders, to differentiate from simple disorders and serious ones, to learn about initial management and prognosis. So the importance of the foot and ankle, they are the structures which are subject to the most weight bearing and loading of the body. They have very important proprioception functions, and their sensory role is very important. Their appearance or deformity is easily noticeable to people. Faulty or improper shoe wear can cause symptoms. With advancing age, deformity becomes more common. So we'll start with some anatomy, the foot skeleton. So here's a diagram of the foot skeleton from the medial aspect. You can see posteriorly is the calcaneus, which forms the heel of the foot. Directly anterior to that is the talus, then the navicular, the first cuneiform, or the medial cuneiform, the first metatarsal, and then the phalanges. So here's an X-ray, again showing the same structures. From the lateral aspect, again, you see the calcaneus, the talus. The calcaneus articulates with the cuboid anteriorly, and the talus, as we saw from the medial side, articulates with the navicular anteriorly. Then you have from this side, you can see the middle cuneiform and the lateral cuneiform, the metatarsals and the phalanges. This is, again, a dorsal view of the foot, showing the same structures. So here are some common disorders of the foot that we will be talking about today. Flatfoot, Hallux Valgus, which is also sometimes called bunion, heel pain, and that is, we're going to talk about plantar fasciitis as a cause of heel pain, ankle sprains and ankle instability, osteochondral lesions of the talus, diabetic foot, and Charcot foot. So first, starting with flatfoot. Flatfoot means reduced longitudinal arches of the foot. Most cases are developmental, meaning the arches do not develop normally. Usually it is painless. Rarely acute flatfoot can be encountered, meaning that the patient did not have flatfoot and then acutely develops flatfoot. Rigid flatfoot can be the result of tarsal coalition. So that is fibrous or bony cross union between the bones of the foot that causes a rigid flatfoot rather than flexible flatfoot. So here are the arches of the foot. You can see in the images on the left, the first one on top is a very high arch, so that is called a pes cavus. In the middle is a normal arch, and the one on the bottom is flatfoot, or what we call pes planus. So here is an X-ray standing. So we always want the X-ray standing to assess foot deformities. And you can see we draw a line through, so you can see the blue line through the longitudinal axis of the talus and through the metatarsals, and it should be a straight line in normal feet. If you have this kind of break in the line with loss of arch, this is what a flatfoot X-ray looks like. So as we said, flat feet can be rigid or flexible. Rigid flat feet can be suspected by a simple test. When the patient is inspected from behind, so you ask the patient to stand, you stand behind the patient and look at the feet, and you ask the patient to stand up on their tiptoes Usually the heel will move inwards. So it will go into a slight varus if it is flexible. In cases of rigid flat foot, the heel does not move inwards. Also on the examination table, when the ankle is held still and the heel is moved sideways, it does not move. Okay, so usually in normal feet, if you move the heel sideways, it moves in eversion and inversion, but in rigid flat foot, it does not move normally. So here's inspecting the heels from behind, and you can see the normal heel, normally the heel is straight or minimally in valgus. This patient has normal appearance of the right heel. So right heel of the patient is in slight valgus and has excessive valgus in the left heel. So the left heel, the left has a flat foot and the right is normal. When the patient stands on tiptoes, both heels correct their valgus and point medially in some varus. So this is not rigid flat foot, and there is no tarsal coalition or bony bar connecting the tarsal bones. So this is flexible flat foot. So management, usually no action is needed for flat feet. Foot exercises are prescribed, but the value is not really confirmed. So there's no strong evidence that foot exercises help a lot in flat foot. Orthotics and insoles are sometimes prescribed as a treatment for flexible flat feet. However, choosing correct and good type of shoes can be of benefit in the long run. Rigid flat feet may require surgical management. So now moving on to Hallux Valgus, which is a developmental foot deformity, as you can see here. And sometimes this is called bunion. So Hallux Valgus means lateral deviation of the big toe, usually at the metatarsophalangeal joint. Often is associated with a bunion, which is the swelling and protrusion at the medial aspect of the big toe. Common in middle age and elderly patients, mainly females. Most cases are painless. When it is severe, it interferes with shoe wear and may cause symptoms. So we have measurements. These are important for you to know. What are the measurements that we take in Hallux Valgus? So these are the measurements we take in a normal foot. These are the measurements. So the first one is the Hallux Valgus angle. And this is the angle between a line extending along the first metatarsal and a line extending along the proximal phalanx. The normal angle is less than 15, so if it's more than 15, that's abnormal. When the patient has mild Hallux Valgus, it can be from 16 to 25, the angle. If the angle is from 26 to 35, this is moderate Hallux Valgus. If the angle is more than 35, this is severe Hallux Valgus. The second angle we measure is the first intermetatarsal angle. And this angle is between the first metatarsal long axis and the second metatarsal. So the angle between the first metatarsal and the second metatarsal is normally less than 10 degrees. If it's more than that, then that's abnormal. The third angle is the Hallux Interphalanges angle, and this is the angle between the long axis of the proximal and distal phalanges of the big toe. Usually, this is less than 8 degrees. So how do we manage Hallux Valgus? The first thing is to correct shoe wear. So make sure the patient is wearing correct and suitable shoes. Avoiding tight shoes. Protect the bunion, which is the medial protrusion. And surgery is reserved for symptomatic and disturbing cases. Following surgery, the patient has to continue proper shoe wear. So this is an X-ray of a patient with Hallux Valgus. Let me just, my screen here is, okay, so people are, so what does valgus mean? Okay, so valgus is a lateral deviation from the center of the body, right? So any bone that is deviating laterally from the center, we call valgus. So if we have valgus knees, it means that the tibia is deviating laterally and the knees are going in medially. So valgus is a type of deformity, the opposite of varus. Second question, could correcting the hallux valgus cause abnormal gait? It should not. No, it should not. It should not affect the gait. Okay. Okay, so this is. Let me just. Okay, so this is an X-ray of a patient with hallux valgus pre-op, and you can see the hallux valgus angle between the first metatarsal and the phalanx is high. The intermetatarsal angle is high. The interphalangeal angle is also high. And this is after surgery. And you can see how everything has now straightened out in the left foot. The right foot is still not treated. Okay, so now moving on to heel pain. Plantar fasciitis is a very common disorder in middle age and elderly. It is insidious in onset. It can be unilateral or bilateral. They have vague pain in the heel region. They have localized tenderness and the site of the insertion of plantar fascia into the calcaneum. So it is usually in the medial aspect of the heel. Plain lateral X-ray of the heel frequently shows calcaneal spur, which is a prominence or ossification at the site of anterior calcaneum and plantar fascia insertion site. So here are X-rays of bilateral calcaneal spurs. These are early. You can see the calcaneus on both sides. On the inferior side, you have like a little beak, a sharp protrusion, and that is what we call calcaneal spur. So plantar fasciitis is commonly associated with flat feet. No visible heel swelling, no skin changes, and no increase in local temperature. There is an inflammatory process at the site of pain. So the plantar fascia insertion site into the calcaneum is inflamed. Heel pain is like stabbing pain when the patient puts the foot on the ground, mostly first thing in the morning. So the first few steps in the morning are very painful, usually gets less after some walking. So this is an X-ray of an advanced calcaneal spur, and you can see at the bottom of the calcaneus, the bottom of the heel, there is what looks like a thorn, okay? A thorn, or this is what we call a calcaneal spur. Management of plantar fasciitis. At present, there's no easy or simple management available. Mainly, the treatment is conservative. It includes stretching exercises to the plantar fascia, actively and passively. We use soft heel insoles and orthotics, which can be helpful. Shockwave therapy may be effective. Local steroid injections are helpful sometimes if the patient does not respond to the other treatments we mentioned. Okay, now moving on to ankle sprains. Ankle sprains are one of the most common injuries, usually occurs during sporting activities, may occur at home or on the street if the patient twists their ankle. It is the result of a twisting injury. There is pain, swelling, and local bruising usually. X-rays don't show a fracture. The injury is partial or complete ligament rupture. So here's a lateral view of the ankle ligaments. So the most commonly involved ligament in an ankle sprain are the anterior talofibular ligament, which connects the fibula and talus anteriorly. Okay, so that is the ATFL. The other one that is commonly involved is the calcaneofibular ligament, which connects the distal fibula and the calcaneus. And this runs in a downward direction. You can see it here. So most commonly injured ligament is the ATFL. Ankle anterior drawer test is used to detect its rupture. So if you have a rupture of the ATFL and you do an anterior drawer test, it will be positive. Other ligaments are the posterior talofibular ligament and the calcaneofibular ligament. The clinical picture of an ankle sprain, always there's a history of a twisting injury. There's pain, swelling, and bruising at and around the ankle. There's no tenderness of the lateral malleolus over the bone itself, but there is tenderness anterior or posterior or inferior to it, which is over the ligaments that are involved. Dorsiflexion and plantar flexion is possible and usually is very minimally painful, but inversion and eversion is very painful because that stresses the ligaments involved. X-rays will show no fractures. How do we manage these? We used to say that the ligament is abbreviated as RICE, so RICE, rest, ice, compressors, and elevation. We used to apply a back slab splint for a few days. So we still do this. We can also use something like in the picture here, like a protective brace instead of a back slab. You should not rest the patient's ankle more than a few days. So a week to 10 days is the maximum. So recently we have expanded, instead of RICE, we use something called PRICES. So P is protection with a brace or a removable boot, relative rest. So rest is good, but only for a few days, not prolonged. Ice, compressive devices, and elevation and support. So support, like the brace in the picture, for walking and for sporting activities. Okay, so then moving on now to osteochondral defects of the talus. Osteochondral defects are abbreviated as OCD. They are very localized areas of joint damage due to lack of blood supply. Lack of blood supply is often post-traumatic, but occasionally there is no cause that can be found. A local cartilage and varying depth of underneath bone are involved and may separate off main talus inside the ankle joint. Usually, posterior medial part of the dome of the talus is the part that is affected. So usually it's the posterior medial part. Sometimes it can be the anterolateral part. There's localized pain on weight bearing and even at rest sometimes. So plain x-rays, you can take a look at them and see, and sometimes you can see a lucency where you suspect that there might be a lesion, but usually you need further imaging. So if you get a CT scan, you look and you see that there is more evidence that there might be something going on. So the lesion is more highly suspected, but the MRI is really what's going to show you the lesion. So the MRI is the standard of choice, and the lesion is confirmed. You can look at the talus, and you can see in the posterior medial corner of the talus, the dark signal or the low signal in the corner, and that is the OCD lesion. Management of OCD depends on how much symptoms and disturbance the patient suffers. So when the OCD is large and loose, or almost loose, then this pushes us more to surgical treatment, which can be in the form of arthroscopic debridement of the lesion and drilling of its crater or the base. Very rarely we can do fixation if there's a very large defect, which has a significant bony part, and we fix it by absorbable screws that after a period of time, the screws are absorbed and don't stay in the joint. Okay, so now moving on to diabetic foot. This is caused by long-term diabetes or failure to control diabetes adequately, and this may result in neuropathy. So neuropathy is nerve damage. It can result in numbness, tingling, and reduced sensation in the feet. There can also be decreased circulation associated with neuropathy and can result in small cuts on the feet being overlooked and becoming infected. Infection in diabetic feet may result in gangrene. Okay, so this is what we call diabetic foot. It's a whole syndrome. So diabetics have to take care of their feet. It's very important, as well as blood sugar control. We advise diabetics to do daily self-inspection of the feet to make sure there are no cuts that have happened without them feeling it. If the patient is unable to do self-inspection due to poor sight or hip and knee stiffness, a member of the family or assistant should do it. Regular inspections by healthcare personnel should be arranged. A visit to a doctor should take place immediately whenever any complication occurs. So what about surgery in diabetic feet? Do we do surgery in diabetic feet? So skilled care of wounds and ulcers in diabetic feet is required. Wound debridement, antibiotics, and repeated dressing should be done. Amputations may become necessary when there is gangrene. Toe amputation or ray amputation sometimes we need to do forefoot amputation or even below or above knee amputations if the gangrene has gone on for a while and neglected by the patient with late presentation to the hospital. Okay, now moving on to Charcot foot. Charcot foot occurs in people who have significant nerve damage to the foot, so it can happen in diabetic people or patients with other causes of peripheral neuropathy where they have damage to the nerves in the foot. The bones of the foot become weak and the joints become inflamed and swollen, and there is laxity in the joints. So walking on the foot leads to disintegration and collapse of the joints and deformity. And the classic deformity is called a rocker bottom deformity. So causes of Charcot foot, any disorder, like I said, which lead to neuropathy. There is decreased sensation and decreased ability to feel temperature and pain and trauma in the foot. Clinically, there is warmth in part of the foot or the whole foot. It may become red or dusky in color. There is swelling in the area. There is pain or soreness. X-ray changes are important to detect and interpret, as early there is no changes. Okay, so early on there are no changes on X-ray, so you have to have a very high index of suspicion. Later on, you start to see haziness, osteopenia, and irregular joint destruction, and further on you see subluxation or even dislocation of the joints. So here is a Charcot foot and ankle. You can see the deformity with protrusion into the arch of the foot because of subluxation and dislocation of the joints, as well as the anterior ankle. So this is a diabetic foot. You can see initially they had first toe amputation, likely because of gangrene. Okay, but the other parts of the foot look quite normal. 3 years or 2 years later, you start to see haziness and osteopenia in the bones. So we'll go back again. So here, the bones, the calcaneum and the cuneiform, the cuboid, the bones look normal, the joints look normal. Here they start to look hazy and osteopenic. And then this is what happens. This is a Charcot ankle. You can see the destruction in the joints. Okay, just a second here. اوكي نرجع. طيب, so this is so she developed a Charcot ankle, and this is the other side. So this is the right ankle, this is the left foot, and you can see early Charcot on this foot 2 years after that. And this is a very, very advanced case of Charcot, and you can see a severe destruction in the bone, and the ankle is basically completely destructed. So how do we diagnose Charcot foot? The main thing is good history and clinical examination. You have to have a high index of suspicion and awareness. So you have to be thinking that about Charcot and know what it is. Exclusion of other causes which may give the similar picture, such as infection or tumors. MRI, bone scans, and aspirational biopsies can help. Non-surgical treatment of Charcot foot includes immobilization, custom shoes and bracing, and activity modification. Surgery may be indicated in certain cases. So this is a case where surgery was done for Charcot foot, where fusion was done between the tibia and the calcaneus using an intramedullary nail. This patient had Mid-foot Charcot joint and reconstruction of the foot was performed with plates and screws. So sometimes we need to amputate and Charcot foot, may be indicated as a last option, mainly when there is severe instability which cannot be controlled by surgery or orthosis. Also when surgery fails to achieve stability. Presence of refractory infection also increases the possibility of amputation. Okay. Any questions about Charcot foot? Or any questions about foot and ankle in general?